It's great. I love it.
If you look at the X-ray, the bone is exactly in the same position like 16 years before. Regenerated bone with machine surface implant. But now let's cross the border of the year 2000. From the year 2000, we continue to do the same procedure, but we change the surfaces. From a smooth machine surface, we went to different kind of rough surfaces. And this is a patient that was treated before and after. And it's very interesting. I did 2 sinus lifts bilaterally. Here she had this kind of a typical Italian junk implants of that period that created a huge defect, as you can see here. So in this case, I did the GBR with a little bit of vertical regimentation in this area, using the same implants. And again, I used just the membrane, without a bone graft, just the membrane and the bone cloth underneath. You see, the same procedure. I don't want to go too slowly. Nice healing, sinus lifts, and 1993, vertical regimentation. The result, pretty nice. But you see that without a filling material, without any bone graft, the regeneration was not 100%, was partial. And we had the implant sticking out from the bone a little bit. And if you look at this situation of the teeth, these teeth were really compromised, but the patient ran out the money, so she didn't want me to touch those teeth. So we continued to root plant these teeth forever. And if you look at the situation, in '94, we have the bridge in place everywhere, and the teeth are still there. After, this is 2004, after 10 years, if I can read, after 10 years, these teeth finished their life. There was no way to continue to maintain. But the resorption of the bone was so much that there was almost no defect. And you see how stable after 10 years are all the implants in the regenerated bone. Then I just removed the teeth. I waited for 2-3 months to make just regular implants. But we are in 2004, so we have changed our implants. And this is the kind of crazy procedure that they recommended to us. I was stupid enough to believe it, because I did the flapless surgery without taking care about the keratinized mucosa, because they told us the rash surface are so good that the fiber can get attached, so much better than a periodontal ligament. Famous histologist said that. So he placed this implant with the fantastic idea to have the rough surface sticking out from the gums. And you see, in a normal bone, very easy procedure, nothing special. So I could think, if those implants are still there, perfectly stable after 10 years, these will last forever. 2004, nice bone. After 4 years, after 8 years, and the patient was coming to my office every 6 to 3 months to the hygienist and to me, and I was not able to do anything for these implants. Because once the bacteria are on the surface, there is no way to get rid of them. So if you look at, this is the final story. I had to remove 2 implants. And if you look at after 18 years, I had the problem also in the machine surface implants. I said, wow, there is a pre-implantitis. It's strange. So I removed the bridge, and the implant was broken. It was not a pre-implantitis, was a failure of the implant structure. So after 18 years, we have stable bone everywhere, but we have lost the rough surface implants. In the same patient with the same surgeon, it means something. Quickly, other patient. You see here, Vertical regimentation, machine implant in 1997. Then the patient lost these implants and this bridge broke. So I placed 2 implants here and 3 implants here. And these are machine and these are rough. After 5 years, machine. After 15 years, machine implants. And this is the situation after 8 years. The bone is there. Completely different behavior. And this is the situation, the clinical situation. When I opened the flap, this is the implant. It was integrated just for 3 millimeters at the apex of the implant. And look at the defect. A huge defect. Then it's difficult to treat again the patient. If you have 1 implant, it's okay. But if you have 6 implants with this kind of defects, it's very difficult to treat them again. And you have to do it for free because you are responsible for that. Look at this case. Vertical regimentation, machine implants in 2002. Rough implant, because in 2002 I still had some machine implants in my office, but I started to buy the new famous rough surface, active surface implants. So I used 3 different, 2002, 2003, 2012, I think. Very good. This has been a little bit compromised by the defect of the adjacent implant. This implant is lost. And the patient was cleaning very well the teeth and was coming to the office every 3 months. Vertical regimentation. 2003, progressive bone loss without possibility of treatment in my office. This is Federico Gualini. He's one of the first dentist or periodontist that did osseointegration with me with Polizzi in Italy in 1987. And he placed an implant, those 2 implants in 2001, machined. And this one was in 2006, much younger. But this is a rough surface implant in the same patient with the same surgeon. Another from Federico Gualini, 1990, 2 implants machine. All these are rough surface, 2002. All failed due to perimplantitis, and these 2 are still perfect in the mouth. This is Isabella Rocchetta. She didn't do this case, but in London, she is working in a dentist's office where they do a lot of all-on-4 with rough surfaces. And you can see here and here, and now they speak about from all-on-4, none on 3, nothing on 3. If you lose one of these implants, then you throw away all the rehabilitation. So it's a very dangerous situation. This is what happens in my office. In 2013, I asked the 2 hygienists I have to look at all the rough implants they have seen in my office in 1 year, in 12 months. So they have seen 226 patients, 898 implants with a rough surface. The perimplantitis were 15% of the patients and 10% of the implants. You could say, that's not bad. But if you look at the numbers, it means that I have seen 34 patients in 1 year with a perimplantitis, which is not possible to treat, and 91 implants. And that's a tragedy, because you see them and you see them again and you see them again. They are not happy. You try to treat them, and the more you try to treat them and the more you are unsuccessful, the more they are angry with you. And I don't want to have that anymore. If you look at this study that has just been published in the International Journal of Periodontics and Restorative Dentistry in January, Filippo Fontana and co-workers has analyzed many patients, 21 patients for 6 years with vertical ridge augmentation. And they found that if you look at the survival rate, they lost just 2 implants, so the survival rate was good, 93.6%. But the survival rate doesn't mean anything, because in the survival rate you have the implants that are going to fail for a peri-implantitis the next day. We have to look at the success rate. If you look at the success rate, we have only 72% of success, which means that in vertical ridge augmentation patients, we have a success of only 70%. We have 30% of the patient with the peri-implantitis. And they have also shown that if you don't have keratinized mucosa, the percentage of success is very low. Almost 50% of the patients have a problem. And if you look at the results, this is a very nice surgery. Filippo Fontana is one of my best students. Now he's not a student anymore. He is about 40 years old, but he's a very good surgeon. Look at this augmentation. Nice bone, is perfect implant position, perfect situation. He did a free gingival graft as well. And the situation in 2008, 2009, 2012, the bone is going, and there is inflammation, exposure outside of the mucosa of the raw surface, which is impossible to keep clean.